Welcome back, students, to the next session of the orthopedics. We'll be talking about the fractures of the lower limb in this section. The important fractures in the lower limb are again divided into the hip fractures, that is the neck of femur fracture, the intertrochanteric fractures, the fractures of the shaft of the femur, that is the thigh, then fractures around the knee joint, fractures of the leg, that is fracture of the tibia and fibula, fractures of the ankle joint, and fractures of the foot. Highlight the important fractures. We'll come to the fractures of the hip, which is the first fracture. In this fracture, it's the intertrochanteric fracture, also known as IT fractures. This fracture is a fracture which extends from the greater trochanter to the lesser trochanter. I'll show you in this picture. This is the hip joint having the head of the femur. This is the neck of the femur. This is the upper part of the femur bone. This is the shaft and the lower end. We concentrate on the upper part, which is the head, neck and the upper segment, which is divided into the greater trochanter and the lesser trochanter. This is the capsule of the hip joint. We are talking about the intertrochanteric fractures, which are extending from a line extending from the greater trochanter up to the lesser trochanter. So this is the fracture line, and usually this extension is from greater trochanter to the lesser trochanter. It is totally extracapsular, that is, it is outside the capsule and it's not affecting the neck region, which is the capsular region, and that's the other fracture, that is the neck of femur. This fracture is 4 times more common than the intracapsular fractures. The age is usually in the elderly people and mostly affecting 60 to 70 years of age. More common in females because of their osteoporotic and patients. The blood supply of the neck of femur or the upper part is very important. It is very precarious blood supply. So it is divided mainly into the extracapsular capsular ring, extra-articular capsular ring, which is further divided into anteriorly and posteriorly. So extending is the fracture, the branch of the lateral circumflex femoral artery, and posteriorly is the branch of the medial circumflex femoral artery. The other branches are the ascending cervical branches and artery to the ligamentum teres. This also can come as an MCQ, where the extra-articular capsular ring, that is anteriorly what is the branch, that is the branch of the lateral circumflex femoral artery, and posteriorly is the medial circumflex femoral artery. That must be kept in mind. The mechanism of injury are again direct trauma, that is in the form of road traffic accidents and history of fall, indirect being due to a muscle pull, and more commonly in osteoporotic people, males and females both are affected, but females are more common. Now, the clinical features of these fractures is there is definitely pain and swelling. Secondly, there is marked shortening of the lower limb. That is because of the fracture, there is a collapse which occurs between the fragments, and because of the collapse, there can be marked shortening of the limb, and that is called limb length discrepancy. The limb in these fractures is there is complete external rotation. It is very important to differentiate between the two fractures, that is the intertrochanteric and fracture neck of femur, where in the intertrochanteric fractures there is complete external rotation. It is extracapsular fracture, while the intracapsular fracture, that is fracture neck of femur, is within the capsule. So there is some amount of the capsule which is still left, and it is posteriorly, so it doesn't allow the complete rotation of the limb. So this is a differentiating factor which should be always kept in mind, and it may be asked in the MCQs. There could be tenderness over the greater trochanter. The radiographic features is a true anteroposterior radiograph must be taken in the anteroposterior view as well as the lateral view of the affected hip. A certain clue can also be got with the help of taking the limb in internal rotation. When you do the limb in internal rotation, if for example this is the limb and you internally rotate while taking the X-ray, this will give a good fracture configuration, especially for fracture neck of femur, and to differentiate between fracture neck of femur as well as intertrochanteric fracture. The treatment is the main objective of this fracture treatment is to restore the normal femoral neck shaft angle. That is the neck and this is the shaft. So this angle must be restored back into its anatomical position. This can be done by both methods, as we already have discussed. It can be either conservative method or it can be done by a operative method in the form of internal fixation. Coming to the conservative treatment, it is mainly indicated in elderly people who are terminally ill. They may be having some medical illnesses and they cannot do. But nowadays, operative management is by far accepted because we want the patient to mobilize as soon as possible, whether it is a young person or an elderly person. He must be mobile or she must be mobile and do their day-to-day activities at least. The methods of this treatment which were done conservatively is using tractions. Traction is in the form of a pulling system which maintain the fracture reduction in the anatomical position. Must take X-rays, follow-up and regular follow-up must be done of these patients to see that a fracture is in place and is not displaced. This is a form of skeletal traction, that is with the help of pins in the form of Steinman pin is most commonly used. Derham pin is used for elderly patients who are osteoporotic. Secondly, in older days, you used to use a fixed skin traction on a Thomas splint. A Thomas splint is a ring splint which is used for the thigh, give a support on the posterior aspect, and a traction kit is used and held at the distal end in the form of fixed, where you don't use weights, and it can be a sliding traction also with the form of weights. The body weight it forms as against the gravity and it causes a counter traction. A derotation bar is in the form of a bar which is kept at the lower end of the foot and keeping in the right anatomical position till the fracture unites. You keep a boot and bar. It's almost in the form of a stand, inverted T, where the support is there in the lower aspect and this is the foot. So this is the boot and bar, or is also known as derotation bar. The word derotation does not allow the foot to rotate. So in that position you will fix it and you will take a check X-ray or see it under the C-arm, which is an image magnification device. If these conservative managements are not working, and by far today's time we want patients to be mobilized as soon as possible and doing their basic routine activities, their daily living activities. So operative methods, if the patient is fit for surgery and there is no other medical illness and medical diseases like diabetes, hypertension, asthma, all these must be in control before doing this surgery, and fitness for surgery is very, very important. The operative methods for these fractures can be in the form of internal fixation device. Earlier used was Smith-Peterson nail with Maglogin plate. The Jewett nail plate was also used, and commonly used implants today's time is gold standard is the dynamic hip screw, also known as DHS, the proximal femoral nail, that is PFN, and the latest ones are the TFN, that is trochanteric fixation nail. But both these implants are used today in this fracture management of intertrochanteric fractures. This is coming to the next topic, coming to the second part of the lower limb fractures, that is the fracture neck of femur, which is another essential part. The diagrammatic picture, this is the region where the fracture has taken place, and this is a fixation with the help of screws, which is known as the cannulated cancellous screws. Again, mechanism of injury is almost similar to the previous fractures. There is always a history of fall. It can be while slip and fall. Secondly, there is lateral rotation of the extremity in which the head is firmly fixed with the help of capsule and iliofemoral ligaments. That is, the ilium bone is a part of the pelvis and the femoral is the femur, that is the thigh bone. And again the neck rotates posteriorly. But as I told you earlier also that in the neck of femur fracture there is no complete external rotation. So the word is partially the limb is rotated. So you can always clinically also make out that this could be a neck of femur fracture and not an intertrochanteric fracture. The intertrochanteric fracture, the foot completely, the lateral side, that is the outer aspect, completely rests on the bed when the patient is lying down. Other causes of injury are the major trauma is seen in the young patients, and they are road traffic accidents which are commonly seen, usually resulting in direct force along the shaft of the femur with or without rotational components. The clinical features is again usually seen an elderly age group, commonly a female, with a history of trivial trauma like a slip or a fall in the bathroom, complaints of pain, restriction of movements of the hip joint. On examination, there is tenderness over the anterior joint line. That is the region over there when you press, and there can be tenderness. Usually the anterior joint line is when you measure from the pubic symphysis, that is center line, and the anterior superior X spine, that is the most prominent point on the hip anteriorly. If you take the midpoint, averagely the midpoint, 1 inch below that is the point where anterior joint line is taken. It's a imaginary line which is seen. There is minimal shortening and partial external rotation. Minimal, as I said, because there is not so much collapse as seen in the intertrochanteric fractures. So again, the shortening is quite gross in intertrochanteric fractures, but not as much in the neck of femur. But till you take a X-ray, it's very, very difficult to conclusively tell that this could be an intertrochanteric fracture or a neck of femur fracture. If there is an impacted neck of femur in the patient, he has usually a groin pain and antalgic gait, that is painful gait, and definitely there will be restriction of hip movements. Sometimes in an impacted neck of femur, the patient may walk and come also to the clinic or the hospital, and you may feel that the patient is all normal, but definitely the patient has got a fracture. So it must be investigated further. Coming to the investigations of the fractures, X-rays or röntgenograms are important and always taken. Anteroposterior view and cross-table lateral views of the hip joint is a must. The affected part, suppose it is the left side, you must take that in the anteroposterior view and lateral view. Always take the lower limb fractures. Maybe there could be concomitant injury. If in case there is a major road traffic accident, you must take fractures of the entire limb, because you should not miss out those fractures and just not concentrate on the hip bone. It could be fracture of the lower end of the femur, knee, and even the leg. The extent of the fracture, whether it is complete or incomplete. The things which are seen on the X-rays are whether the fracture is complete, that when the fracture neck is there, whether it is completely broken or is partially just involving a certain part of the neck is easily seen. Secondly is the fracture angle. This is the neck shaft angle, which is usually seen around 120 to 125, and this will be grossly changed because of the fracture of the neck. The head will go into varus, that is, it will come much lower and the angle will definitely reduce. So different classifications are there for the fractures later, which we'll discuss. There is break in the Shenton's line, that is the continuity from the pelvis, that is lower part of the pubic symphysis. When you extend it down towards the neck, and go down towards the shaft, it forms a smooth curve. that is known as the Shenton's line, extending from the pubic symphysis, that is the pelvis, going to the neck, again to the shaft. This is broken in neck of femur. Posterior wall combination in the lateral view is also easily seen, and degree of osteoporosis. Usually these fractures are seen in the elderly, so the level of osteoporosis, how weak it is. So accordingly, after the fracture has been fixed, you must give treatment in the form of calcium, multivitamins, like vitamin D, supplementation is also done. In this X-ray, that is pelvis with both hips is taken, that is the pelvis bone as well as the head, neck and the shaft is seen, and this in the right side is the lateral view. You can clearly see that there is a fracture which is extended from the lateral part and extending downwards. That is giving you a clue to the fracture. And earlier mentioned in the previous presentation also that you must try to take the leg in internal rotation view. Around 15 degrees of internal rotation will clearly give you a imaging which will help in knowing that this is a fracture neck of femur. Coming to the treatment part, the treatment again is divided into immediate line of treatment, that is the patient must be relieved of pain with giving analgesia and immobilization in this ring splint or the Thomas's splint. A pre-operative skin traction which is used. You must always do the treatment of other injuries. The patient may have, in case of road traffic accident, he may also have fractures of the skull, head injuries and other limb injuries may be also component there. And you must treat the patient as a whole, not just the fracture, like in this case fracture neck of femur. Other medical treatment of other medical conditions, like you must treat the diabetes, hypertension, any other diseases. If he's got old history of cardiac conditions and asthma, these must be also taken care of. When these fractures also take place, there can be severe, if it's a compound injury, patient may lose lot of fluids and there can be hypovolemia, that is the whole blood circulation may drop down, as well as electrolyte balance, that is acid-base balance imbalance may occur. So you must take care that all these things also must be looked after, and most importantly the blood. So if there's a lot of loss of blood, the patient definitely may have anemia, that is hemoglobin levels will fall down. So in the form of, after doing all this treatment, you must do a definitive management. So after doing the basic treatment, you must come to the definitive line of management for these fractures. This is usually, again, open reduction has been, or closed reduction is usually done, and internal fixation of this fracture is must. This can be done either with the help of cannulated cancellous screw, that is CC screw, which is used. There is second method is the HEMI arthroplasty in the form of Austin-Moore prosthesis and bipolar prosthesis, which is today now commonly done. There are newer techniques, that is modular bipolar techniques, which have also come today. And finally is the total hip replacement, that is complete replacement of the head and even the acetabular part, which is done today. And lastly is the girdle stone excision arthroplasty, that is in some young patients you may have to just excise the head and neck part and not put any implant in C2. Implants which are used for internal fixation are the Moore pins, commonly used especially in the younger age group. The Moore pins are used, again devised by Austin-Moore. Secondly is the cannulated cancellous screw as shown in the previous picture. And lastly is the dynamic hip screw, that is again the DHS implant can be used even in fracture neck of femur. This is a diagonal picture of a fracture neck. Image is seen extending, there is the intracapsular. So because it's being intracapsular, important thing is the vascularity is easily hampered. So all the blood supply is affected, so that you have to fix it as early as possible. Unlike in extracapsular fracture, like intertrochanteric, you can do it at much later stage also. It is not an emergency thing, especially if you want to preserve the head. This is a diagrammatic picture of in the anteroposterior view, the neck of femur, as well as the lateral view, where you can clearly see the fracture line. This has been beautifully treated by the help of cannulated cancellous screw, and usually put in a figure in a triangular fashion, where all the three corners is the point where the cannulated cancellous screws are inserted. You have to reduce the fracture firstly and then fix it with the pins, or in this form is the cannulated cancellous screw. If you cannot get a reduction with a closed maneuver where you are manipulating, where the word close I mean manipulation, if you can't do it, you have to go in for the open reduction. You have to open the joint, see the fracture configuration, reduce it, and then fix the fracture, not hampering the vascularity further. The osteoarthritis, which is an important part, it can be also caused because of the avascular necrosis of the hip and also malunion. Avascular, by the word, is that the vascularity is lost, and if the blood supply doesn't come to the head, it gets necrosed and there will be complete resorption later. So treatment of choice for these patients in young, we must try to preserve the head as much as possible. So you must do either an osteotomy and get the vascularity back, or secondly arthrodesis, that is fusion. By the word arthrodesis is fusion. While in elderly patients, you can safely replace the whole head. This is a non-union fracture neck of femur, a part of fracture neck, where after a certain period of time, specifically in 3 weeks, if the bone doesn't unite, especially in this neck, it will definitely cause non-union. That is, by the word non-union, it's not causing the union of the fracture fragments in the anatomical position. Otherwise, non-union is defined as fracture which is not united at least 9 months period of time. But in some bones, especially the neck of femur, scaphoid fractures, talus fractures, these are precarious bones and their vascularity gets easily hampered, and in case of neck of femur, even in 3 weeks time, it can cause non-union. The factors influencing the incidence of fracture neck of femur are various factors are age, that elderly age group is more affected. Secondly, the sex, females are more prone. Sedentary lifestyle, those patients who have got sedentary lifestyle are their bones and vascularity from the muscles is not much, so definitely become easily weak, osteoporotic, and their fracture neck of femur can occur common in them. Then is the race, the nutrition, very very important factor, especially in elderly age group. If there's not good diet, whether it's vegetarian, non-vegetarian, if it's not, definitely the bones become weaker. And there are addictions like the smoking, alcohol, which can also hamper the vascularity. And atherosclerosis is one of the causes which will block these blood vessels. Medications like corticosteroids, that is steroid injections or drugs, thyroxines, sedatives, tranquilizers, anticonvulsants can also cause hindrance in the blood supply, and other medical conditions are also there. The treatment of choice for these elderly patient is the HEMI arthroplasty, and today's time there is Austin Moore, and this is the bipolar prosthesis which is used. By the word bipolar, it's got two surfaces, the head and the upper cup, which will rotate and give much more flexibility and good range of motion. There are complications of arthroplasty and hemiarthroplasty as well. You must take care of them while doing the surgeries, intraoperative as well as postoperative. There could be fractures of the femur, while intraarticularly when you are reducing the fracture or placing the prosthesis, there can be a concomitant fractures of the femur extension. There could be complete dislocation of the head. Thirdly, there could be sepsis, that is infection. There could be the loosening, that is the whole implant may become very loose, and you can see that on the X-ray. And lastly, there could be complete proximal migration of the prosthesis and protruding into the acetabulum. Few further images which will make it very clear. The whole implant has come out and there's complete dislocation of the head, and the implant has come out from this anatomical position. This complete dislocation. By the word, you must know the two different things, that is subluxation and dislocation. Subluxation is partially it is moved, while dislocation is completely out of its articular surface. In the image you can see that there is loosening of the implant where there is lysis, and it is the area which is marked with the arrow is the radiolucency is seen, and that is easily seen. The third important is protrusion into the acetabulum. Here, because it is the protrusio acetabuli, that is the implant has gone into the acetabulum. There is migration of the complete implant which is seen. Finally, the other method of treatment is the total hip replacement. So you can clearly see that this is a avascular necrosis patient. Right side he still has the avascularity. Left has been replaced by total replacement, where the implant has replaced the femoral section as well as the acetabular part has been also done, replaced with the help of a cup. Coming to the complications of the fracture neck of femur, they are divided into non-unions. The non-unions are approximately 30 to 40%. Most common cause is inadequate immobilization. When the patient comes, you have to immobilize the joint and try to treat it as soon as possible. Secondly, because the precarious blood supply I already mentioned, that is the decreased blood supply to the proximal fragment will lead it not to cause the union. Patients a lot complain of pain and difficulty in weight bearing on the affected limb. Coming to non-union fracture neck of femur, which is an important part. Coming to local examination, the limb is again short, externally rotated. Again in this form is partial. The increased range of movements at the fracture site, that is there is mobility which takes place at the fracture site because the proximal and distal fragments are not united. So there is continuous movements, that is we call it as abnormal mobility. Trendelenburg test is positive and telescopy test is positive. Coming to the Trendelenburg test, which is important even for practical point of view. This test is testing the abductor mechanism, that is abductors muscles are checked in this test. The test is very simple. You have to do it in a stepwise manner. The patient is male or female, is stripped from the waist downwards. You must be able to see the hip bone, I mean the posterior aspect as with the anterior part very well. Secondly, you must always examine the patient from behind. Ask the patient to stand on the normal limb first. Example, if my left limb is normal, I will stand and flex the other limb completely. Ask him to stand or her to stand in that for around 30 seconds without taking any support. Then after that, ask him or her to keep the limb down, and now ask to stand on the affected side, that is in this case right. You must do the same step and observe the movement of the pelvis. When you do in the normal side, as what I am doing now, completely the right side gets elevated up because the abductor of the left is normal. It is pulling the pelvis in the one direction, and the pelvis will tilt and the right side will go up. Similarly, when I stand on the affected side now, instead of the pelvis, the opposite side should come up. It stays at the same level or it sinks down. So that is an important thing. In short, if you want to remember, a mnemonic is sound, side, sinks. Sound is the normal side, side sinks. So when you stand on the affected side, as in this case the right side, the normal side or the sound side will sink. That's the easy way to remember. So this is a practical test as well as an important thing which can also come in the MCQ. Coming to the other test is also known as the telescopy test. And the word telescope is one fragment is going into the other. In this case, the shaft is one, because the neck femur is this thing, it's like a tube, one tube going into another. So when you do a movement, it's easily you can palpate the whole joint has been moving just like a telescope, going in and out of one tube of the other. So these are the two tests which are very, very common and always positive if it's a non-union fracture neck of femur. You must get Trendelenburg test positive as well as telescopy test positive. The treatment of the non-union is based on the age as well as the vascular status of the head. If this patient is about 60 years, generally, you must go in for the replacement arthroplasty, that is complete changing of when the head is removed and you again replace with the implant. While young patient, I said earlier that you must try to preserve the head, because you must try to give the normal anatomy to the young patients. So it can be done by neck reconstruction by the Buxey's method, where he uses multiple screws as well as muscle pedicle graft in the form of tensor fascia lata. Other techniques are osteotomies in the form of Powell's osteotomy, where the intertrochanteric osteotomy at the level of the lesser trochanter is done. So this is the lesser trochanter and the osteotomy is done at the level of the lesser trochanter. So that is Powell's osteotomy, and try to restore back the neck shaft angle. The valgus effect also created at the fracture site is to convert the shearing forces into compressive forces. Once you make the shearing, that is the forces which are pulling the fragments away, into compressive forces, that is uniting them, it will definitely facilitate the union of the fracture. Another complication is aspect in the fracture neck of femur after non-union is avascular necrosis. Again, the vascularity is gone, and then there will be slowly the whole head gets resorbed and patient definitely gets pain and difficulty in walking. All the medullary blood supply and capsular blood supply are cut off, leaving only blood supply to the ligament teres, that is the single arterial blood supply, which is insufficient to give it to the blood supply to the head and result in avascular necrosis. In the X-rays, you can clearly see that the head is deformed, totally collapsed, and there will be complete collapse of the head. So in this treatment, still in young patients, we can go in for hip arthrodesis, that is fusion of the joint. Secondly is bipolar arthroplasty can be thought of, Meyer's procedure, and lastly, rarely, girdle stone arthroplasty is done. But elderly patients, we will always try and go in for a replacement in the form of replacement HEMI arthroplasty. This is a clear picture of the avascularity of the head, where you can see that the head congruity is not maintained, it is deformed, is not smooth, and secondly there is a good amount of collapse. So this is a clear example of avascular necrosis. There could be many reasons why avascular necrosis of the head occurs.